Greetings. I'm Dr. James Wiseman, Assistant Professor of General and Minimally Invasive Surgery at the University of Arizona in Tucson. Today we'll be discussing one of my favorite topics, and that is the widespread issue of hernias in general surgery. First, disclosures are appropriate whenever they are necessary, and I should start by telling you that I am a proctor for Intuitive Surgical on the Da Vinci robotic system. Second, I have made every effort to fully credit images as well as information to their source. Where I've failed to do this, it should not be interpreted as malicious. Simply let me know, and I'll be happy to make the update as expeditiously as possible. Thanks. The most important thing to understand is what exactly is a hernia. In some ways, they're sort of like fine art. You know them when you see them, and we've all seen them. Really, there are two ways to think about hernias. The first is in the more elegant understanding that comes through medical training. The second is through the eyes of the patient. Now, I've heard patients describe hernias in many ways over the years, and these are just a few of my personal favorites. Probably most common is the perhaps partially correct understanding of a hernia as a hole in my stomach. Again, not technically accurate, but it at least reflects the public's recognition that it involves a hole somewhere where there shouldn't be one. It's a good starting point, at least. More than occasionally, I'll get that patient that describes it as a bulge in their groin. This is certainly more descriptive of their symptom rather than the problem itself, and usually these folks need a fair amount of coaching to understand what has led to the presence of a bulge that they probably wish wasn't there. I've encountered somewhat more comical descriptions of hernias over time as well. One gentleman was reminded of the climactic scene in the old Sigourney Weaver movie Alien, where the title character pushes its way out of her abdominal wall. In retrospect, I have to admit that in his particular case, the comparison wasn't really all that far off. Then there are the more colorful dramatists of society, such as the young man who insisted that intestines were actively fleeing his abdomen through the back door. You can't make this up, folks. If you spend enough time in medicine, you'll see and hear just about everything. But we're all future doctors here, except, of course, for those of us who happen to already be doctors. So we're going to make an attempt from this point forward to think of things in terms of doctor words. So let's try to define hernias in a more technical sense. For this purpose, I will turn to my good friend, Ms. Merriam-Webster, who defines a hernia as a protrusion of an organ or part through connective tissue or through a wall of the cavity in which it is normally enclosed. And Miss Webster, being the evil genius that she is, will actually use the word hernia in a sentence or even connect you with more information about hernias if you are so interested. That's awful nice of her. But let me take a stab at defining hernias as I understand them. And I'm a simple man, so I think of them as an opening, usually abnormal, although not always, that permits the contents of a space to exit that space. And the concept of hernias is actually quite widespread in medicine. For obvious reasons, most of us immediately think of groin hernias as the quintessential example of a hernia.
Oh!
But perhaps even more common than groin hernias are hernias that occur at the belly button. I'm sure that our aspiring obstetricians and pediatricians will remind us that at some point we all had an umbilical hernia. Of course, this may be the only example known in which the majority of these hernias ultimately fix themselves. Even neurosurgery can't escape the concept, and in this field we see the devastating complication known as uncle herniation. No, 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 not that kind of uncle. There we go. That's the right one. All right, I'll admit that was a very thinly veiled attempt at injecting an unexpected uncle joke. What can I say? I'm not a neurosurgeon. At any rate, from the realm of spine surgery, we get the concept of vertebral disc herniation. The point is, hernias aren't unique to general surgery. You'll see this idea time and again throughout your career, so it's worth spending the time to get comfortable with it now. So with all these different hernias running around, which ones fall in the wheelhouse of your average general surgeon? Well, groin hernias, of course, as these are the types of hernias most often seen in both men and women. Ventral hernias, with ventral being a catch-all term to describe hernias that occur in the anterior half of the abdomen. Hiatal hernias are very specific hernias that involve the natural partition between the left and right diaphragm through which the esophagus travels to become your stomach. Internal hernias is another descriptive term that describes virtually an infinite number of hernias that occur within the abdomen that are not included elsewhere in this list. And then another broad type of hernia treated by general surgeons are those that occur in the posterior half of the abdomen. Collectively, these are known as lumbar hernias. We know a lot about hernias, but perhaps the most incompletely understood aspect of hernia disease is its biology. For example, we know that many factors influence hernia formation, and the presence of any single factor alone is probably not enough to lead to the development of a hernia. There is also a lot we know about the molecular changes that take place in the setting of a hernia. Most of you know that there are at least 3 types of collagen found in human tissue, and the integrity of the tissue is largely dependent on the ratio of collagen type 1 to collagen type 3. Well, it has been widely described that a common characteristic of tissue in which hernias develop is a shifting of this ratio to a more equal mix of types 1 and 3 fibers. So far, it is unclear how this observation might be applied in either the treatment or prevention of hernias, but it is interesting nevertheless. Finally, in the case of inguinal hernias, there does appear to be some influence of genetic and familial inheritance patterns. This influence is not completely understood, but it does appear that certain human genotypes are more prone to inguinal hernia formation than others. So let's start with groin hernias, as these are the most common. The lateral boundary of the inguinal canal is formed by the iliac crest, with the symphysis pubis forming its medial counterpart. The roof of the canal is formed by the aponeurosis of the external oblique muscle. The spermatic cord is an aggregation of structures that traverses the abdominal wall through the inguinal canal. These structures include the vas deferens and the arterial inflow and venous outflow of the testicle, encased by fibers of the cremaster muscle. Not contained within the spermatic cord, but also traversing the inguinal canal along with it, is the first of 3 important sensory nerves that are important for you to remember, because I promise that you will be asked about it at some point. It's called the ilioinguinal nerve and generally mediates sensory information from the skin of the lateral scrotum and medial thigh. The spermatic cord and ilioinguinal nerve enter the abdominal wall through an internal opening known as the internal ring, which is not seen in this figure, and exits through the external ring before descending into the scrotum. All of this, of course, is only in men. In women, this space contains the round ligament and is often obliterated under normal conditions. In this image, borrowed from our good friend Dr. Gray, we see that the aponeurosis of the external oblique muscle, as well as the muscle itself, has been removed. This reveals a number of structures that are pretty important to the hernia surgeon. Chief among these is the inguinal ligament, also known as Poupart's ligament. Most traditional hernia repairs rely on this structure to provide strength to the repair at the inferior border of the newly reconstructed canal. We also begin to see the femoral canal, which it turns out is also important to the anatomy of the groin. It is also useful to remember that there are 2 sets of obliquely oriented muscles. We encountered the external oblique in the previous slide. When that gets removed, we can see the fibers of the internal oblique muscle underneath. Although not shown here, one of the three most important sensory nerves in the world of the hernia surgeon generally runs along the anterior surface of the internal oblique muscle, and that is the iliohypogastric nerve. We have now reflected away the internal oblique muscle as well, and get our first view of the internal ring mentioned 2 slides ago. We can also see for the first time that the floor of the inguinal canal is formed by the transversalis fascia. This fascia also has an important role in many of the traditional tissue-based repairs. The conjoint tendon, which is another term that you are likely to hear at some point, is a thickened portion of the common aponeurosis of the internal oblique and the transversus abdominis as it inserts into the pubic crest. There is one more structure worth mentioning at this point, and this is the pectineal ligament, also known as Cooper's ligament. This is an extension of the inguinal ligament that runs below it along the pectineal line. This forms the floor of the femoral canal and historically was utilized during some approaches to hernia repair, such as the McVeigh repair. It's worth mentioning that during a typical open hernia repair, it takes a little extra work to identify Cooper's ligament, and in the most common modern repairs, it actually isn't often seen. I mention this because at some point while scrubbed into one of these cases, you will be asked what ligament will be involved in your suture line inferiorly. You will be tempted to say Cooper's ligament. I implore you, if you do decide to answer Cooper's ligament, make certain that you are doing a McVeigh repair. No discussion of groin anatomy would be complete without addressing the relevant nerves important to the hernia surgeon. There are 3 main sensory nerves to know and have a general understanding of. These include the ilioinguinal nerve, the iliohypogastric nerve, and the genitofemoral nerve, more specifically, the genital branch of the genitofemoral nerve. As mentioned, these are sensory nerves, and this cartoon demonstrates their general areas of sensory distribution. However, one of the biggest challenges in the management of chronic groin pain after hernia repair is that there is great variability in the overlap of these distributions from patient to patient, and this variability is probably impossible to predict. However, you should have general knowledge about these distributions as you may be asked about it, and it will likely also make you a better physician. When it comes to groin hernias, there are 3 main types that we see. The most common is an indirect inguinal hernia. I have labeled the inferior epigastric artery here because it represents the most useful boundary differentiating the 2 types of inguinal hernias. In this case, indirect hernias occur lateral to the inferior epigastric artery. These represent somewhere between 80 and 90% of inguinal hernias, and it is beneficial to think of an indirect hernia as one that essentially follows the spermatic cord through the inguinal canal toward the scrotum. The second type of inguinal hernia is a direct hernia. These occur medial to the inferior epigastric artery and are far less common than their indirect counterparts. These result from a disruption of the floor of the inguinal canal itself. The third and least common type of groin hernia is the fabled femoral hernia, which traverses the femoral canal. Back when I was a medical student, we had lots of useful acronyms, and I'm going to reach way back into the darkest recesses of my memory to pull out one of those now, because it is useful in understanding exactly what this hernia is. Anyone remember the acronym NAVAL? Huh? Go ahead, take your time. I'll give you a minute. No, that sure is a pretty boat, but I'm not looking for naval as in N-A-V-A-L. I'm looking for naval as in N-A-V-E-L. Try again. Oh boy. How about one more try?
Ew, gross!
No, not that naval either. Shout out to my daughters for the assist with the soundbite, by the way. The structures of the femoral canal from lateral to medial include the femoral nerve, femoral artery, femoral vein, a so-called empty space, and then the lymphatic channels. Thus, the acronym NAVAL. Now I have a confession. When I was a medical student, I was convinced that the empty space didn't really exist. In reality, the authors of First Aid just needed a way to make their silly little acronym work. Now, almost 15 years and dozens of femoral hernia repairs later, I'm finally convinced. There really is an empty space there, and that really is where unfortunate souls occasionally tend to get a hernia. Just as in our acronym, that empty space exists just medial to the femoral vein. In fact, just about the only thing that is inaccurate about this cartoon is just how comfortable the subject in the images seems to be with chitlin poking through a very tight space. These patients are invariably extremely uncomfortable, and these hernias are often very difficult to feel clinically. So when do we fix growing hernias? The most obvious answer is when they are symptomatic. Most, but not all of these patients present with a bulge, and at least two-thirds of them will report some degree of discomfort associated with that bulge. This discomfort often resolves by applying manual pressure or lying down. Thankfully, severe pain is rarely present, even with movement, and very small percentages of these folks report pain at rest. One of the bad things that can happen with growing hernias is that they can become incarcerated, essentially meaning that the bulge is stuck and can't be pushed back in. The risk of this is relatively low, and only about 5 to 15% of growing hernia repairs are performed on incarcerated hernias. The implications of an incarcerated hernia are completely dependent upon what is incarcerated. Most commonly, it's just preperitoneal fat stuck in there. And while this can be wicked painful, it doesn't represent an imminent threat to survival. On the other hand, if it is a loop of intestine stuck in there, we have a different story. Intestines are like a constantly flowing garden hose. When you kink the hose, flow stops. This concept also applies to intestines. When a loop of intestine passes through a small hole like that found in a growing hernia, it becomes kinked. Just like the garden hose, flow can then stop. We call this obstruction, and it isn't necessarily an imminent threat early in the obstruction. However, as more and more stuff piles up behind that kink, the obstruction actually becomes worse. Eventually, if given enough time, that intestine will become strangulated. And unlike Bart Simpson, prolonged strangulation will lead to the death of the involved intestine. Translocation of bacteria will start to occur, and the patient will eventually turn septic if left unaddressed. The bowel can also perforate, exacerbating the sepsis. The problem here is that it is not just the lumen of the intestine that gets kinked. The lumen of the blood supply to that intestine will also become kinked, and there will be no blood flow to the strangulated bowel. At any rate, it's a big problem that demands quick action. We also fix growing hernias when they are femoral hernias. They don't even have to be symptomatic, although they almost always are. This is because the femoral canal is a very tight space, and this leads to a very high risk of incarceration, obstruction, and eventual strangulation. So femoral hernias are fixed as soon as they're identified, most of the time anyway. So what about asymptomatic inguinal hernias? Historically, the approach to these has been much more nuanced. When I was a resident, we learned that you never really had to operate on these, and in fact might not even be justified in doing so. More recently, however, the American College of Surgeons has given us some very good guidance on this. In general, asymptomatic hernias should always be fixed in women, and the preferred approach would be one of the laparoscopic platforms. This is because femoral hernias are more common in women. Only a few of the traditional approaches to growing hernia repair adequately address femoral hernias, whereas all laparoscopic or robotic approaches are well suited for these types of hernias. Second, young, healthy men might be good candidates for watchful waiting. Overall, the risk of one of the more catastrophic complications of hernias, such as incarceration with resulting strangulation, is low, and watchful waiting spares the patient the potential complications of surgical repair. Men older than 60 who are physically active and fit for surgery ought to be offered repair. This is because they are likely to progress to a symptomatic status within 2 years, and recovery gets more difficult the older you get. Just ask my lower back. It'll tell you. Finally, patients with asymptomatic hernias and chronic progressive comorbid conditions might also benefit from early repair before their condition deteriorates to a point where surgery would no longer be safe. How about imaging? Is there any role for CT scans, ultrasound, or MRI in the management of growing hernias? Well, here's a meta-analysis of the literature published in 2013. They concluded that herniography is the best study. Now you're probably asking yourself, what the heck is herniography? And I'm glad you'd asked. This study involves injecting contrast directly into the peritoneal cavity through the abdominal wall. It will fill the hernia, which can then be seen on imaging, and it performs well in sensitivity and specificity analyses. But there's also the risk that you might inject the contrast into something other than the peritoneal cavity, such as intestine. This can lead to perforations. There can be reactions to the contrast, and it just generally feels like a rather invasive and risky way to get this information. So herniography really isn't done anymore. So what about ultrasound? Well, it is fairly sensitive and specific, but that is for all comers, including those patients in which a bulge can be palpated. And the intent of the ultrasound is simply to confirm that what you're feeling is a hernia. When there is no palpable bulge, it performs considerably less well, and this is precisely when it would be most useful, unfortunately. CT scan also performs well overall, with slightly lower sensitivity and specificity than ultrasound. But the same criticism applies here, and CT scan is a much more expensive study than ultrasound is. It also subjects the individual to a non-negligible dose of radiation, so that also ought to be considered. Finally, MRI has a comparable sensitivity. Of the four studies, however, it is by far the more expensive. Certainly, cost alone would dictate that MRI shouldn't be a routine study used in the workup of groin hernias. These findings led the authors of this meta-analysis to recommend the use of ultrasound where there is real uncertainty with respect to the presence of an inguinal hernia. In other words, if you feel a bulge and the bulge behaves like a hernia on exam, no need to get an ultrasound to prove it. In fact, they don't see much of a role for CT scan in the diagnosis of inguinal hernia. There is a small caveat worth mentioning here, however. Femoral hernias can be notoriously difficult to feel on examination, and more than one surgeon has been surprised to find a femoral hernia on CT scan after convincing themselves that there was no hernia present clinically. In general, though, I don't use CT scans to look for inguinal hernias. So what if you feel a bulge, but it doesn't behave like a hernia? Or you have a reason to suspect that it may be something other than a hernia, such as a large lymph node? MRI can be used to sort that out. But these cases should be rare, and MRI should be used sparingly in this setting. If you still can't sort it out after ultrasound or MRI, then it might be reasonable to proceed to surgery. This is particularly true in the area of laparoscopy. Otherwise, perhaps a little bit of watchful waiting might be the most prudent approach. If it is a hernia, those have a way of declaring themselves given enough time. When it comes to repair, there are essentially two approaches available. Traditionally, these have all been performed open, typically with an incision right over the hernia. There are many ways to do this, either with the use of a synthetic, biologic, or biosynthetic mesh to reinforce the repair, or by utilizing a tissue-based repair without the use of a mesh of any kind. The other approach is laparoscopic, which includes either traditional laparoscopy or the newer robotic approaches. And these repairs come in essentially two different flavors, something called a totally extraperitoneal preperitoneal repair, or TAP, or a transabdominal preperitoneal repair, also known as a TAP. These are some of the traditional tissue-based repairs. Don't worry, you won't be asked how to perform any of these. But if you like history like I like history, you might find them interesting. One of the more well-known is the McVeigh repair, which I mentioned earlier. In this operation, the transversalis fascia is sewn directly to Cooper's ligament medially, and the inguinal ligament laterally. This leads to a great deal of tension on the repair, which is alleviated by making a relaxing incision on the external oblique aponeurosis. The Bassini is similar, except that instead of just sewing the transversalis fascia to the inguinal ligament, Dr. Bassini took a great big bite of everything he could find and sewed that to the inguinal ligament. There was no relaxing incision, and this repair typically performs poorly in terms of recurrence. My personal favorite is the Schuldeis repair, devised by Edward Schuldeis. This is a 4-layer laminated repair that results in a fairly significant alteration of the anatomy of the inguinal canal. It features not one, but 2 relaxing incisions and has reported recurrence rates as low as 0.5%. One of the newer tissue-based repairs is the DeSarda repair, originally described in 2001. This repair essentially mimics one of the more common mesh repairs, utilizing a free flap of external oblique aponeurosis instead of synthetic mesh to recreate the floor of the canal. Finally, there is the Marcy repair, which essentially simply aims to tighten a dilated internal ring, as you would see in an indirect hernia using suture. Most hernia repairs performed in the United States are done with mesh. The most common approach is known as the Lichtenstein tension-free repair, which essentially uses synthetic mesh to reconstruct the floor of the inguinal canal. There are other approaches as well, but the commonality among them all is that they use mesh to accomplish a function that would otherwise be served by native tissue. The advantage of the mesh in almost all approaches is that it relieves the repair of tension, which is oftentimes the enemy of the general surgeon, and it elicits the formation of scar tissue, which ultimately gives strength to the repair. Regardless of whether you are performing the operation laparoscopically or robotically, through a totally extraperitoneal or transabdominal approach, the goal of laparoscopic groin hernia repair is this view. This is what is known as the myopectineal orifice. This view includes the indirect space lateral to the epigastric artery, the direct space medial to the epigastric artery, and the femoral canal. The repair consists of covering all three spaces with a single piece of mesh. One of the most difficult to manage complications in modern times is post-herniorrhaphy pain, which is defined as pain persisting more than 3 months after surgery. In general, there are 4 different types of post-surgical pain, and one of the greatest difficulties is determining which one is present in any given patient. Nociceptive pain is usually related to tissue trauma, whereas neuropathic pain is most commonly caused by injury to one of the 3 sensory nerves that run through the groin. Somatic pain is most often caused by injury to the bony structures of the groin area, and visceral pain is usually related to irritation of the spermatic cord or ischemia of the testicle from compromise of the blood supply to the organ. It is probably a much more common complication than most people think, ranging in incidence from 11% to 18%. Thankfully, it runs a spectrum of severity with only a small percentage of these individuals experiencing life-altering pain. The use of mesh certainly increases the risk of chronic pain, but is not the only culprit. Risk is correlated with whether sutures or tacks are used to fixate the mesh, or if it is fixated at all. Additionally, some evidence suggests that it is less likely with a laparoscopic approach. Gender appears to play a role, with females being at a higher risk. Young people are also at a higher risk of chronic pain. Finally, those undergoing reoperation for recurrent hernias also appear to be at a higher risk of chronic pain syndromes. One phenomenon worth knowing about is that of the so-called meshoma. This results from mesh shrinkage and folding, leading to the formation of a mesh ball that can entrap nerves and tissue, leading to chronic pain. This is one I took out of a 43-year-old who had severe scrotal pain for 2 years after a laparoscopic repair. His pain went away after this meshoma was completely excised. Other complications of hernia repair include infection, hematoma, seroma, sexual dysfunction, urinary retention, orchitis, and testicular ischemia. So the million-dollar question in groin hernia surgery is, does it really matter how you get the job done? Well, let's look at the numbers. This table comes from the Textbook of Hernia 2017 publication. Shout out to Dr. Chimikungara and Goldblatt for doing the hard work for me. First, let's talk about arguably the only outcome that matters, and that is whether or not the operation actually gets the job done. Across the board, open tissue-based repairs, open mesh reinforced repairs, and laparoscopic repairs have comparable recurrence rates. I will mention that the Shouldice Hospital in Toronto has reported their outcomes on more than 280,000 Shouldice repairs, and they report a recurrence rate of about 0.5%. However, those outcomes haven't been reproduced elsewhere, so we'll assume that the 4 to 10% recurrence rate shown here is accurate. Early data on the robot, by the way, indicate that recurrence rates of 2 to 5% should be expected. But then we look at the outcome that is probably most important to me, and that is chronic post-herniorrhaphy pain. Open no mesh, laparoscopic, and probably robotic repairs are significantly lower in terms of incidence. This can be a challenging and costly complication to deal with. If we have opportunities to reduce its occurrence rate, we ought to consider them. With respect to wound complications, rates are generally low, although it does appear that laparoscopic approaches perform better here. In fact, it seems that the only area in which laparoscopic approaches do worse is with postoperative urinary retention. Although this is a discomforting occurrence for patients, it is time limited and relatively simple to address. In many cases, it leads to the discovery of undiagnosed underlying benign prostatic hypertrophy, which allows us an opportunity to further improve their lives by referring them for treatment. So the question of whether approach matters can largely be left up to the individual surgeon and the patient. The task of the hernia surgeon is to know the merits of each approach and understand when to apply them. That brings me to my favorite topic, and that is ventral hernia. So just as with groin hernias, it is useful to start with a discussion of the anatomy. This is a review for most of you, but my advice would be for you to periodically review this anatomy as you move through your career in medicine. Also, Recognize that the posterior leaflet of the rectus sheath disappears below the arcuate line. So the anatomy depicted here is relevant above the arcuate line only, which is usually a few centimeters below the umbilicus. The strength of the abdominal wall, and by that I mean the layer that holds your chitlins in, is the anterior leaflet of the rectus sheath. Ventral hernias are classified by where they lie along the abdominal wall. The labels to the far left are most useful to you, and if you were on my service, I would expect you to at least be able to identify hernias as subxiphoidal, epigastric, umbilical, infraumbilical, or suprapubic. With respect to primary abdominal wall hernias, or hernias that aren't associated with an incision, size is characterized by the diameter of the defect itself, not the sac. Small hernias are those less than 2 centimeters, and large hernias are those with a diameter greater than 4 centimeters. Everything else is described as medium in size. Incisional hernias are exactly what you might expect them to be, hernias that occur at the site of a previous surgical incision. It's worth taking a moment to consider the scope of the problem here. Roughly 1/4 of all laparotomies result in a hernia. In the United States alone, there are approximately 2 million laparotomies performed per year for various reasons. In essence, potentially 500,000 hernias are being created annually, and that's just in the United States. As you can imagine, this is an expensive problem to deal with. Best estimates suggest that it costs us more than $3 billion every year just for the surgeries required to fix all these hernias. This doesn't even account for those costs associated with hospital stays or complications that result from those operations. There are a number of factors that are known to place individuals at a higher risk of developing an incisional hernia. The first has to do with the location of the incision, with midline incisions being at the highest risk. Complications are also known to impose a cost in terms of hernia risk. The most important with respect to this risk are those known as surgical site events, or surgical site occurrences. The most important of these are infection, the formation of a postoperative hematoma, postoperative seroma, or a dehiscence, which refers to those rare occasions when the abdominal closure fails very early in the postoperative period. There are also a number of what we call modifiable risk factors, meaning we can exert some degree of influence over their impact. Undoubtedly, the most important of these is smoking, which imposes a 4-fold increase in the risk of subsequent hernia occurrence. Intuitively, this should make sense to you. Nicotine is a vasoconstrictor, and the end result of vasoconstriction locally is that there is less oxygen available for consumption by healing tissue. Furthermore, less blood flow leads to fewer fibroblasts in the area, and a decrease in the deposition of the collagen vital to tissue strength. In my own practice, I won't electively repair a ventral hernia until a patient can demonstrate 6 months of abstinence from smoking. Recently, I've added vaping to this list as well. The impact of smoking on wound healing cannot be overstated. Obesity also seems to have an influence on the risk of hernia formation. Within the last year, however, evidence seems to indicate that this is due to an overall increased risk of surgical site occurrences due to the obesity. It is unclear whether the risk of hernia formation is related to the underlying obesity itself, or if it ultimately is attributable solely to the increased risk of surgical site events. Malnutrition, as defined by an albumin of less than 3 milligrams per deciliter, is also a risk factor. Obviously, you need protein to heal, and the absence of available protein certainly contributes to the risk of hernia. However, malnutrition tends to accompany many other states associated with general unhealthfulness. And the reasons why malnutrition portend postoperative hernias are probably multifaceted. Immunosuppression, such as that which accompanies many cancer treatments, rheumatologic treatments, and even primary diseases such as HIV, is also a known risk factor. And finally, poor blood glucose control, whether it be from diabetes or steroid use or whatever, is associated with a higher risk of hernia. Similar to obesity, however, this appears to be related to the overall increased risk of wound infection. Classification of incisional ventral hernias differs from their primary counterparts in one main way, and that is size. I will spare you an in-depth review of this slide, but from the perspective of the hernia surgeon, it is not the diameter of the incisional hernia that matters, but rather the width of that hernia. This metric has implications regarding the repair of the hernia that aren't important in this setting. Unlike Groen hernias, there is little enthusiasm for non-mesh repairs of incisional hernias. The reason is that recurrence after primary suture repairs is almost a 50-50 proposition at 3 years. And at 10 years, odds are better than not that the repair has failed. However, with the advent of mesh, This rate has been reduced to around 30% at 10 years. Still not spectacular, but certainly much more palatable. What we now understand is that the most important factor influencing the durability of the repair is the choice as to where that mesh is placed. Let me show you what I mean. Let's return to our abdominal wall anatomy. Mesh can essentially be introduced into any layer of the abdominal wall with various strengths and weaknesses of each option. Let's start with the onlay option. This operation was popularized by Dr. Chevrel in the 1970s and was born out of his belief that hernias were primarily the result of disruption of the linea alba, which he believed to be the linchpin of the abdominal wall. His approach essentially used flaps created from the anterior leaflet of the rectus sheath to recreate the linea alba, and a synthetic mesh to recreate the anterior sheath that he had just borrowed. Mesh placed below this, essentially spanning the hernia itself, is said to occupy an inlay position. This has largely fallen out of favor as a primary repair, although I occasionally use it in staged procedures. When mesh is placed behind the muscle, it is said to be a sublay repair. My students and residents will frequently hear me talk about a retrorectus or a rivus stapa repair. That is an example of a sublay repair. Finally, when the mesh is below the posterior leaflet of the rectus sheath, it is said to be in an underlay position, and there are two flavors of underlay repairs. The first is called a preperitoneal underlay, which implies that the mesh is sitting outside the parietal peritoneum, in the preperitoneal space. The second is termed an intraperitoneal underlay, with the mesh contained within the abdominal cavity itself. So what do you do with those really large hernias with really large defects? You know, like the guy with the alien popping out of his abdomen. The worst nightmare of any hernia surgeon is getting a patient open only to realize that they cannot get the edges of the rectus sheath together, or that they come together but under too much tension. Remember, tension is the villain in the story of general surgery. Historically, this has been addressed with the use of that inlay approach that I mentioned in the previous slide. But do not despair. We have new options at our disposal. My personal go-to operation is the posterior component separation, or transversus abdominis release. This operation was popularized by Dr. Yuri Nowitzki out at Columbia in New York City and is enjoying increasing adoption by hernia surgeons due to its versatility. The idea is that you access that retromuscular space just as you would with the rivus stapa repair. That space can then be developed as far laterally as the neurovascular bundles, which penetrate the posterior sheath from below. Really, if you go beyond these, you've gone too far. But an absolute boundary is another important anatomic structure that you have also probably heard of. It is called the semilunar line and sits right out here. The posterior sheath is then divided approximately 1 centimeter medial to those lateral neurovascular bundles we just discussed, making every effort to preserve them. This exposes the underlying transversus abdominis muscle. The transversus abdominal muscle is then divided about 1 centimeter lateral to its medial edge, giving you access to the associated retromuscular space. Complete division of this muscle along this edge will buy the surgeon considerable mobility of the rectus sheath. I've routinely used this approach to close defects in excess of 20 centimeters in width. It's a wonderful tool. The other option is an anterior component separation. There are a few ways that this can be done, but one popular method is to start by creating a skin flap laterally, allowing wide access to the anterior leaflet of the rectus sheath. This leaflet is divided first beyond the lateral edge of the rectus abdominis muscle, and then again at the medial edge of the muscle. The muscle is mobilized within the sheath envelope, which will then allow the surgeon increased mobility of the fascia to attain a tension-free closure. As with groin hernias, both open and laparoscopic or robotic approaches have been described. Specific strategies for accessing your desired space are being developed all the time, and I like to tell the residents that the only limitations are those imposed by your own imagination. Probably the two most important factors in the choice of approach are the individual skill of the surgeon and the size of the defect. Certain patient factors such as obesity favor laparoscopic or robotic options, but most experienced hernia surgeons can adapt each of these techniques to any conceivable patient characteristic. There are a number of hernias out there that we haven't discussed and probably worth mentioning. For example, the obturator nerve occupies a space known as the obturator canal deep in the pelvis. It's a space, so hernias can occur there. When they do, You might have guessed that they are called obturator hernias. There is also something known as a Spigelian hernia. This is a partial thickness hernia through Spiegel's fascia that occurs along the semilunar line. These are typically quite symptomatic and notoriously difficult to diagnose clinically. Additionally, they are at high risk of incarceration and ought to be repaired when diagnosed. Internal hernias include those that occur at naturally occurring spaces, including paraduodenal hernias and foramen of Winslow hernias. Additionally, hernias can occur through the substance of the omentum with the same clinical effect. There are also hernias that occur through the back of the abdominal wall, collectively known as lumbar hernias. There is a Petit's hernia, which occurs through the inferior lumbar triangle. The corresponding entity through the superior lumbar triangle is known as a Grinfeld's hernia, which sounds a lot like Gryffindor. And there's only one way to help you remember this one.
Expecto Patronum! Expecto Patronum!
Well, there you have it. That might actually be everything that I know about hernias. If you have any questions, by all means, feel free to reach out to me by email. And in the meantime, stay safe out there.